With the pressures of commissioning for value comes the need to understand the current and future health needs of your local populations. Risk adjustment and casemix are tools that can help CCGs set budgets or capitation rates and evaluate provider performance. The traditional approach to benchmarking, something like emergency admission rates, would compare GP practices to the CCG average. However, this takes no account of the differences in casemix between different GP practices, so doesn't reflect the impact of morbidity and multimorbidity on service demand. What I hope to show you is that by using casemix you get a much more informed picture of practice performance, based not just on comparison of actual activity across the local population, but on what the patient data expects from each practice, based on the morbidity of their populations. This graph shows the emergency admission rate for each GP practice, and the orange line shows the CCG average. Because the population sizes are going to differ for each practice, the report shows the number of admissions per 1,000 patients. If we only compare practice rates with the CCG average, it appears that practices 2, 3, 4, 6, 7 and 10 are performing worse than the others. But when you compare the actual practice rates with their expected rates, when their casemix is taken into account, a different picture emerges. Some practices with high emergency admission rates are actually performing as well as or even better than some of those with lower rates. And some practices with seemingly low rates are actually performing worse than you would expect for the morbidity burden of their patient population. Casemix adjustment provides a fairer method of analysing variation in activity and shows that opportunities for reducing activity are not necessarily among the GP practices with the highest activity levels. Let's now look at the opportunity for cost savings when actual activity is compared with the expected activity that has been casemix adjusted. This table uses primary and secondary care data processed by the Johns Hopkins ACG system to show actual and expected activity and expenditure for a 12-month period for a practice's diabetic patients. Where actual activity and costs exceed the casemix adjusted expected amounts, there may be potential to reduce activity counts and expenditure. Where significant opportunities appear, you can use this intelligence to investigate how practices are commissioning secondary care or prescribing drugs. Visually representing casemix adjusted activity data can give you immediate clues as to potential areas that could benefit from further investigation, while year-on-year data can highlight the effects of service changes. For insights into how Clarity Patients and the ACG system can help you commission for value, go to www.solis.co.uk.